Diagnosis of precocious puberty number is defined by puberty before the age of 8 years, identified by using Tanner scale. Idiopathic precocious puberty is the main cause. It has two ways, central or peripheral central, high generate and treated by generate analog, peripheral high RH, high FSH and treated by surgery. Surgery to assist or depends on the main cause diagnosis, Tanner scale, or the drop-in level to know if it's central or peripheral dependent or independent. That you have ultrasound MRI to check the structure on the molar sprain or gonad. And central precocious puberty generate dependent precocious puberty in central precocious puberty in every endocrine and physical physical aspect of puberty. Further development is normal, but true only idiopathic precocious puberty, which occurs much more often in females than in males. Males with precocious puberty have a higher incidence of CNS disorders such as tumors and hematomas precipitating the precocious puberty. Overall, idiopathic precocious puberty is the most common cause. Almost any condition that affects the CNS, including hydrocephalus, meningitis, encephalitis, supracellular sepsis, trauma, epilepsy, intellectual disability, and irritation can precipitate pre-central precocious puberty. Diagnosis, laboratory tests, several evidence and FSH, increased generate stimulation tests, gold standard, evaluate the reactivity of the hypothalamic pituitary axis to generate stimulation, gonadotropin, RH, and FSH, will increase after intravenous administration of GnRH, serum, testosterone, estradiol, increased imaging, X-ray of the non-dominant hand and wrist, and MRI of the brain with contrast when increased analysis confirms to rule out intracranial causative pathology. And diagnostic algorithm, if advanced over an age of X-ray over 1 year difference between bone age and chronological age measure baseline. Elate, you indicate central puberty diagnosis with RH is normal. Perform GnRH stimulation tests if analyze the increases in responses of central puberty, then perform MRI to rule out intracranial causative pathology. GnRH independent precocious puberty. Mecklen-Erberg syndrome is the most common cause of GnRH independent precocious puberty. Other causes include adrenal carcinoma, adrenal adenoma, HCG, secreting tumors, seminoma, optic hypothalamic glioma, ovarian cyst, CAH in female, primary hypothyroidism diagnosis, laboratory tests, serum muscle FSH, and age decrease generate stimulation tests, no increase in age level after generate, ultimately serum testosterone, estradiol levels increase depending on the tumor, T3 informant, suspicion of hypothyroidism, imaging X-ray of the non-dominant hand and wrist. Precocious puberty in GAR is defined as the development of secondary sexual characteristics before the age of 8. The condition can be categorized into central gonadotropin dependent and peripheral gonadotropin independent precocious puberty, which is distinct etiology. A systemic approach to diagnosis is crucial for identifying the underlying cause and guarding clinical evaluation in history, age of and onset of breast development, pubic hair growth, and menarche rate of prevention of pubertal changes, associated symptoms such as vaginal bleeding or discharge, headaches, visual disturbances or erected growth, family history of precocious puberty or related endocrine disorder, physical examination assessment of gross velocity and height, staging of breast and pubic hair development according to the standard stage, identification of any neurological deficit, convulsions, suggestive of neurofibromatosis or signs of hypothyroidism, diagnostic test, bone age assessment, advanced bone age is typical in precocious puberty assessed by a hand and wrist X-ray, other RH and FSH level, elevated levels, such as central precocious puberty, low or prepubertal level may be seen in peripheral or precocious puberty GnRH stimulation test. A definitive test for central precocious puberty are significant rise in RH, especially an FSH after GnRH administration confirms central situation of the hypothalamic pituitary gonadal HPG axis. Pelvic ultrasound to assess the size and structure of the ovary of the endometrius can identify ovarian cyst or are curious in the case of precocious puberty. Entering of the brain, particularly the hypothalamic pituitary region to exclude CNS lesion like hypothalamic hamartoma tumor in case of central precocious puberty. So thyroid function tests to exclude hypothyroidism which can occasionally be or contribute to precocious puberty. Differential diagnosis central precocious puberty CPP due to early activation of the HPG excess causes can include idiopathic, most common CNS lesion or genetic condition, peripheral precocious puberty PVP, independent of HPG excess activation causes include the ovarian cyst, tumors, mitochondrial syndrome, or accidental exposure to sex steroid. Incomplete precocious puberty such as isolated premature tenarchy, breast development, or premature anarchy, pubic hair development without other sign of pubertal activation. This condition are benign and do not progress to puberty management consideration. The clinical approach depends on the type and the cause of precocious puberty. Central precocious puberty can be treated with GnRH. Analog to delay further puberty development until an appropriate age for peripheral causes. Treatment is directed at the underlying causes such as surgery for ovarian tumors or managing mitochondrial syndrome symptoms. Psychological support and counseling may be beneficial for the child. Then finally, due to the social and emotional challenges associated with precocious puberty, higher place precocious puberty in girls require careful evaluation to distinguish between central and peripheral causes, with central being more common. Combination of clinical assessment on age, motherhood, tropin level, and imaging steps is crucial for diagnosis. Early diagnosis and appropriate management are essential to prevent physiological compromise, other health, and psychosocial issues. So let's somehow diagnosis of precocious puberty in a birth, defined by puberty before the age of 8 years, identified using the Taylor scale. Idiopathic precocious puberty is the main cause to a central or peripheral. Peripheral central high GnRH treated by GnRH. Central high GnRH and treated by GnRH, although peripheral high efficacy, and generally by surgery if tumors tester depend on the main cause diagnosis. Taylor scale according to the tropin level to know if it's central or peripheral dependent or independent. We just saw the MRI to check the structure of abnormalities, brain or organelles. Central precocious puberty, GnRH dependent precocious puberty. Secondary precocious puberty, every endocrine and physical aspect of pubertal development is nowhere but to OE. The idiopathic precocious puberty, which occurs much more often in female than in males, men with precocious puberty have a higher incidence of CNS disorders, such as tumor, hematoma, precipitating precocious puberty. Over there, idiopathic precocious puberty is the most common cause. Almost any condition that affects the CNS, including hydrocephalus, meningitis, encephalitis, brucellosis, head trauma, epilepsy, intellectual disability, and irritation, can precipitate central precocious puberty. Diagnosis, laboratory tests, thermometers, and FSA increase generate stimulation tests or standard evaluate the reactivity of the hypothalamic pituitary axis to generate stimulation. Gonadotropin H and FSH level increases after intravenous administration or FSH. Throughout testosterone estradiol will increase imaging X-ray or of the non-dominant hand. The risk MRI CT of the brain with contrast to an increased LH is confirmed to the intracranial causative pathology. Diagnostic algorithm you advanced for nasal on X-ray for 1 year or 1 year difference between bone age and the core chronological curve age measure baseline LH increase central puberty diagnosis RH is normal low perform generate stimulation test. If LH increase in response to central puberty, then perform MRI to intracranial causative pathology generates independent precocious puberty. Meconius-Albert syndrome is the most common cause of generates typical precocious puberty. Other causes include the adrenal carcinoma, adrenal adenoma, HCG, secreting tubercle, germinoma, optic hydrothalamic glioma, ovary cyst, CH in female primary hypothyroidism diagnosis. Laboratory tests, serum muscle FSH and NRH decrease. GnRH stimulation test no increase in NRH level after GnRH administration. Serum testosterone and estradiol level increase depending on the tumor. TSH, T3 hormone of suspicion of hypothyroidism remains history of non-dominant hand and wrist. Clinical evaluation history is and rate of progression of puberty changes, critical examination, staging of friends and pubic hair, identification on any other neurological physical response, diagnostic testing, knowledge assessment, further areas and stage level, generic stimulation test, pelvic ultrasound, MRI, the brain, thyroid function test, depression diagnosis, central precocious puberty, CPP, and peripheral precocious puberty, PPP, and complete precocious puberty, such as isolated premature anarchy. Management consideration of the time and cause of birth could repair causes treatment is directed out of the line conditions such as surgery or tuber or managing with coronary blood nerve symptoms. Central precocious puberty can be able to regenerate. Allow to delay further development until the appropriate age, a higher point of precocious puberty in girls. Careful evaluation to distinguish between central careful cause which the drawing more common. Combination of clinical assessment of both age but of atrophy level and imaging studies crucial for diagnosis. Only diagnosis and appropriate management are necessary to prevent early PBC or closure, performance, other take, and psychosocial issues.